Welcome, everyone. Before I begin, I recognize that we may be joining from many different parts of the province today, and I want to acknowledge the homeland of the many diverse First Nations, Métis, and Inuit people whose ancestors have walked this land since time immemorial. We honor and respect their history, languages, ceremonies, and cultures, and are grateful to work, live, and learn on these traditional treaty territories and Métis lands in Alberta. My name is Lana, and I'm a senior analyst with the Health Quality Council of Alberta. We are a provincial agency that brings together patients, families, and our partners from across healthcare and academia to inspire improvement in patient safety, person-centered care, and health service quality. I'm excited to share with you what we learned from residents during in-depth interviews about their experiences in designated supportive living from January to March 2020. I would like to take a moment to thank Alberta Health Services, site leaders and operators, and the residents who participated in this work, because without you, it truly was not possible. And I would also like to thank Alberta Health Services, and all of the providers and frontline staff within our healthcare system. The COVID-19 pandemic has been an incredibly challenging time, to say the least, and I want to thank you and the continuing care sector as a whole in your efforts to protect and keep Albertans safe. So thank you. This province-wide study in 2020 was in follow-up to the 2017 HQCA I'm Still Me, the lived experiences of residents in designated supportive living pilot study that was conducted in the Calgary zone and confirmed the feasibility and value of doing similar work across Alberta. Through this pilot study, we heard that it provided meaningful resident experiences and that expanding the scope of this work to all zones was needed. We also heard that there was a need to improve the balance in the number of residents that lived in high and low ranking sites, according to the overall care rating sites received from the HQCA Designated Supportive Living Resident Experience Survey. So the overall care rating question asks residents using any number from 0 to 10, where 0 is the worst and 10 is the best. Overall, what number would you use to rate your home? Using responses to this question, sites were ranked by this overall care rating, where sites at the top were identified as high ranking and those at the bottom were identified as low ranking. So this work was expanded province-wide in 2020 with the purpose of understanding what factors contributed to residents' experiences and to explore if residents' experiences differed based on whether they lived in a high or low ranking site. 27 residents who were men and women younger than the age of 65 and those who were older and lived in their home for different lengths of time participated in an interview between January and March 2020. These residents were from 18 designated supportive living sites that ranked high and low and were from rural and urban locations throughout Alberta. 12 participants were from high-ranking sites and 15 participants were from low-ranking, and about half of the participants were from urban and rural locations. Now, I want to take a moment to acknowledge the impact of the COVID-19 pandemic on this work, because there was an additional 13 interviews scheduled to be completed. And these interviews were canceled because of the restrictions that were implemented within continuing care to keep residents safe. It was also recognized that the context of residents' lives had shifted quite considerably because of the COVID-19 pandemic, and it would impact their experiences in designated supportive living. So the 27 completed interviews were analyzed, and this revealed common themes about residents' experiences. I also recognize that the current pandemic context may be quite different from the times prior to the pandemic. Learning what residents themselves feel contributes to their experiences will continue to be important, as their voices provide valuable insights about how to improve the lives and experiences of residents in designated supportive living. So during the interviews, residents were asked to reflect on their experiences before, during, and after their move into designated supportive living, their lives at the present moment, and whether their lived experience in designated supportive living aligned with their expectations. So, from our analysis, key findings were identified that describe what was learned from residents' experiences. So, let's go through each of these in some detail, where residents' experiences will be described through quotes and examples that use names that have been changed to protect residents' identity. Our first key finding is that, in general, residents shared similar experiences with respect to transitioning into and living in designated supportive living. And this is regardless of age, sex, geographic area, site rank, and how long they had lived in their home. In some specific instances, differences were present, and I will call some of these out where relevant in this presentation. Our second key finding is that residents' expectations or their beliefs about what life would be like in their new home and designated supportive living are linked to their lived experiences. In particular, residents' expectations were formed in different ways before they moved into their new home. For some residents, the values and aspirations that they had accumulated throughout their lives, such as pursuing health and wellness goals or taking part in activities that were consistent with their lifelong interests and values, informed how they wanted to live life in their new home. Others had former experiences with congregate care that informed what they thought life would be like in their new home. So, this was either through their work history, by visiting a family member or friend in congregate care, or by previously living in a congregate care setting. For example, some residents thought that the meals, the level of care, or the size of their suite would be similar to what they had experienced in their previous congregate care home. And lastly, residents' expectations were informed through the information and service descriptions that they received about their new home from family, sites, and healthcare professionals, such as a social worker. This information was also presented in a positive manner, which often created unrealistic expectations about what life in their new home would be like, especially as it related to the quality of the meals and the dining service. When residents moved into designated supportive living, they compared their expectations to their lived experiences and decided whether their expectations were met or not. And notably, some residents did not have any expectations. This evaluation of their lived experiences impacted how they experienced aspects of their move into designated supportive living, how they adjusted to life in their new home, or how they experienced care and services that were being provided in their new home. So let's go through an example of each of these where we can see the connections, starting with an example of exceeded expectations. So residents' expectations were exceeded when their lived experiences were better than expected. Most often, residents describe their experiences positively because they moved into designated supportive living with lower expectations. For example, Norma expected the cleanliness of her new home and her own personal hygiene to be poor due to her past experiences visiting congregate care homes, but she was pleased that this was not her experience. Our next example is of met expectations, where residents' lived experiences aligned with their expectations. For example, Ronald understood what his life would be like in designated supportive living because he had previously worked within congregate care. In circumstances such as these, residents described their experiences in generally neutral terms because it was what they expected. Now, our next example is of unmet expectations, where residents' expectations were unmet when their lived experiences were worse than expected. And in a situation, residents were more likely to describe their experiences negatively. For instance, Cynthia expected the quality of care and services would be similar to what was provided in her previously congregate care home. Her expectations were also based on how the manager of her former home described the features and services of her new home. However, Cynthia's expectations were unmet because the meals and the level of walking support were not the same, which made it quite difficult for her to adjust to life in her new home. Some residents, particularly those who were older, did not have previously formed expectations about what life would be like in designated supportive living. So, this happened if a resident had no previous personal experience with or limited knowledge about congregate care, and if their move was sudden or unexpected due to changes in their health. So, for example, Phyllis was coming to her new home from the hospital, and she was quite scared and had many unanswered questions. So, under these circumstances, residents often experienced anxiety because of the unknowns. So, what we learned from residents' experiences is the importance of understanding, setting, and managing expectations with residents before they move into designated supportive living to improve their understanding about what life in their new home will be like. So, this can be facilitated by healthcare professionals such as transition or home care nurses, and especially by site operators and staff who play a critical role in supporting residents during their transition. In doing so, residents may experience less uncertainty or surprises from not knowing what life is going to be like, and it could improve the likelihood that their expectations will be met, which may help residents have more positive experiences. For instance, in Matthew's experience, he had no surprises because he was told what to expect before he moved into his new home. Our third key finding is that moving to a new home is challenging for most residents. So, why was it challenging? Residents felt moving was difficult because it was often experienced as a sudden and major life event that they were not always ready for. Some residents had spent time considering the changes in their health and need for support, or they gradually accepted that they would need to move into designated supportive living while others had not. And although some residents considered their circumstances and health changes, they were not always prepared for a sudden health decline that resulted in hospitalization and a necessary transition into congregate care. For example, Eleanor had talked with her doctor and she considered moving into a new home, but she decided to stay in her home for as long as she could until she couldn't live at home anymore and she was hospitalized. When a decision had been made to move into designated supportive living, residents reported that there were limited housing options to choose from, and in some cases, only one option was available. And this was especially true for residents in rural areas who reported limited and less desirable options, such as having to live within a hospital unit. For example, Kimberly is a rural resident who explained that she had limited choice in where to live because she either had to choose her current home or move to another city entirely, which was not an option for her. It was also challenging primarily for older residents because they felt they lacked information about their new home and an orientation to their new living environment. For example, they did not know how long it would take to receive their meals, were unaware of what amenities or transportation were available, or how to get around their new home without getting lost. This lack of information made residents experience moments of fear, stress, uncertainty, disappointment, and confusion. And we can feel this uncertainty with Eleanor's experience when she had to watch other residents to see what they were doing when she first moved in. In general, residents who felt they lacked information about their new home lived in low ranking sites. And lastly, moving to new living circumstances overall was quite difficult, especially for older residents who had more recently moved into designated supportive living. And this is because they were most likely to grieve the loss of their previous home and the space and privacy that it afforded them. So we can see this from Shirley's experience, where she was moving from her own place that was just herself and her dog to a completely new home. And this was quite difficult for her because it was a change in lifestyle. Now, regardless of these challenges, residents reported that their move was made easier for a couple of reasons. First, their move was easier when they were supported by staff who made them feel cared for by being welcoming and supportive. For instance, Phyllis was quite scared when she was moving into her new home, and she was afraid of being a burden. But the caring and patient staff was helpful in easing those challenging feelings that she was experiencing from her move. Also, residents, particularly those who were older living in urban areas, reported that their family made their move easier because they helped them set up their suite to make it feel more like home. And they also helped them cope by visiting regularly and providing them with emotional support. And this was especially important for residents like Norma, who appreciated that her family kept coming back to visit and look after her. And she felt that this made the transition easier for her. Our fourth key finding is that residents adjust or become more comfortable with life in designated supportive living at their own pace, as some residents settled in more easily than others. So, what influenced how residents adjusted to life in their new home? First, residents adjusted more easily when they personally accepted and managed change. So, this involved residents who generally coped well with change, those who perceived personal benefits to their move, such as having meals cooked for them, or they recognized that they needed more support and accepted that they would benefit from the transition as a whole. And we can see this in Nancy's experience, where she had no problems adjusting because she felt ready for life in her new home. Residents were also able to adjust well when they could continue as much as possible to live life in their new home in familiar ways. And this involved being engaged in meaningful activities that reflected their personality and passions, engaging in lifelong habits like smoking, cooking, or bathing as often as they were used to, having their freedom, choices, and desired degree of independence respected, which was especially important for older residents, and having access to home like amenities that they were used to, like a kitchenette, personalizing their suite, and having staff that treated their suite as their home. For example, Carol really appreciated that staff treated her like an individual and she could be herself. Our last factor that helped residents adjust better was feeling part of their home's community when they developed meaningful connections and friendships with other residents and staff. This was particularly important for women like Kimberly because they valued being able to relate to, laugh, and joke with other residents and staff. So now that we've covered what made adjusting easier, what made adjusting more difficult for residents? So, in many cases, residents who face challenges with adjusting to life in their new home often experience the opposite of what I just shared. So, they felt unable to live their lives as they were used to. For instance, older residents like Raymond struggled when they lost independence and became more reliant on staff's help, especially for bathing. Or residents felt unable to connect to or develop friendships with other residents and staff. Most residents felt that it was difficult to adjust to life in congregate care. And this was because they had to learn new routines and adapt to the schedules and staff of their new home. For instance, Eleanor said that it took her a long time to get used to her new home because she had to adjust to a different way of life through the schedules and the shifts and how she felt about other people. As well, residents had to learn to live with other people and become accustomed to less privacy, since most were used to living alone. Lastly, some residents living in rural locations experienced difficulties adjusting when they felt trapped and isolated within their new home. And this was because their new home's location was quite far from their family, it was in an isolated location, or lacked transportation options. And the impact on residents who felt this way can be seen through Philip's experience, who felt like he's been in jail if he's not able to get out. Our final key finding is that residents discussed common factors they felt influenced their experiences. Many of the residents interviewed had lived in their home for some time, from at least 3 months to over 10 years, and they reflected on what life was like for them now. So first, what made experiences better from residents' perspective? By far, residents felt the personal relationships that they had with friendly, patient, and respectful staff contributed to more positive experiences. And women and men talked about this differently, where women like Denise liked it when staff took a personal interest in their lives. For example, Denise appreciated that staff were super nice. They listened to her and they cared about what she had to say, while men valued that staff were easy to get along with. Residents also felt it was important that they receive gentle, unrushed, and timely care that skillfully met their needs and accommodated their preferences. For example, Carol was appreciative that staff were there when she needs them. Next, residents felt a home-like environment that was spacious, clean, scent-free, and provided access to areas that they enjoy, such as an exercise room, a library, and a garden, made their experiences better. For example, Lois especially liked the sunroom, library, and activity room of her home, and she appreciated the comfortable chairs. And lastly, residents appreciated access to a variety of activities and social opportunities that were consistent with their personal preferences. So these activities provided residents with enjoyment and ways to connect and sustain their relationships with other residents. So for example, from William's perspective, he really enjoyed that there was always something new. So now that we've covered what made experiences better, what did residents say were the opportunities for improvement? The opportunity for improvement that residents talked about most often was better aligning the meals and dining service with their preferences, as this was not always the case. Although residents from both high and low ranking sites discussed improvements to the meals, residents from low ranking sites voiced this perspective most often. As well, older residents like Philip expressed the desire for meals to be plain, well cooked, and appropriate for diabetics. So, in Philip's experience, he expressed that older people do not like modern food. Now, with the dining experience, older residents, mainly from low ranking sites, felt that the dining experience was not always home-like. And this was because meals were scheduled at set times, seating was assigned, and meals were pre-plated. Next, residents felt that there were opportunities to better maintain their autonomy in the ways that they wanted. So residents talked about this. Some were quite frustrated when they were unable to choose their own mattress or were required to purchase a hospital bed out of pocket, or when they were unable to self-administer their own medications or were required to use their home's pharmaceutical provider instead of a more affordable and trusted local pharmacy. And using a local pharmacy was most important for rural residents like Catherine. So these experiences made residents feel like they lacked autonomy and they wanted to be able to do these things if they could. Our last common opportunity that residents, particularly those from low-ranking sites, talked about was wanting to feel safe and comfortable to voice their concerns and have their concerns addressed and addressed in a timely manner, as this was not always the case. As well, older women were especially hesitant to express their concerns because they feared reprisal against themselves and staff. So, for example, Shirley questioned the purpose and effectiveness of the resident and family council at her home because the concerns that were raised at these meetings went unaddressed. And she also reported that residents do not express their concerns to management in general because they take it out on the staff. The key findings from this study highlight opportunities to facilitate more positive experiences throughout residents' transition into designated supportive living and beyond. Specifically, it is important for healthcare professionals such as transition or home care nurses, and especially site operators and staff who are involved during residents' transition to support residents' understanding about what life in designated supportive living will be like before they move into their new home. Site operators and staff can also provide residents with an orientation and be kind, welcoming, and empathetic towards residents when they move in to help residents feel supported in their new home. During this transition, it is important that staff personalize the support that is offered to help residents adjust in meaningful ways. So, this personalization can involve helping residents to live their life in familiar ways, meet and socialize with other residents and staff, and become familiar with their new home and community. Further, site operators and staff can facilitate more positive experiences by helping residents develop personal relationships with staff and by providing timely and proficient care, a home-like environment, and meaningful social activities. Residents' experiences can also improve by considering ways to provide meals that better align with their preferences and helping them to maintain their autonomy in the ways that they desire and listening to and addressing their concerns. Overall, these experiences with residents revealed that understanding and honoring each resident as a person through the ways of being and living that are important to them matters most to their experiences in designated supportive living. So this finding is consistent with the 2017 HQCA I'm Still Me pilot study, which found that residents' experiences were more positive when they felt their personal interests, lifestyles, and expectations were preserved. By better understanding residents' experiences, leaders, operators, and staff can learn how to best support residents as individuals throughout their entire designated supportive living journey. So thank you all for taking the time to join me today and learn about residents' experiences in designated supportive living from January to March 2020. If you have any questions about what I shared with you today, please feel free to reach out by email at supportiveliving@hqca.ca. Thank you again for joining me, and I hope you have a great day. Goodbye, everyone.